Thank you so much. Thank you so much for being here today. So I'm going to be talking about something that is truly an honor for me, something I'm very passionate about, and that is honoring tradition and um, our Native American elders. Again, I am Shauna Parisian. I'm a registered dietitian, and I'll be sharing my perspectives that blend professional science with cultural understanding so that we can uplift. Sorry about that. I lost my screen. Okay, sorry about that. um, in ways that we can honor both tradition and health for our Native American elders. So before we get started, I just want to take a moment to recognize that we are celebrating National Nutrition Month. This year's theme, set by the Academy of Nutrition and Dietetics, is Discover the Power of Nutrition. And that's something that really resonates deeply. Every year, I really find their message to be integrated into our community very easily. But understanding the power of food today and its role in our health. If you're looking for resources to celebrate National Nutrition Month, if you're participating in any health fairs, I encourage you to visit eatright.org. And there they have a lot of quizzes, they have a lot of fact sheets and things that you can use, a lot of graphics for social media and tools that you can use to support wellness and community education where you are. So, a little background information on me. I am mother of four children. I'm also a grandmother. I am from the Turtle Mountain Band of Chippewa, where I was born and raised. And if you're not familiar where my reservation is in North Dakota, it's in the north central part. And here I have a map of North Dakota. So right at the top there, that little square, that's the Turtle Mountain Reservation. It's a relatively small reservation, very beautiful. We are remote, so we are considered a food desert. Um, and my experiences combine both working within private sector as working with a corporate company for food service management, and also within the last 10 years working within Indian Health Services. The first portion of that, working down in Arizona, northeast part of Arizona, serving the Hopi and Navajo Nation. And within the last 2.5 years, moving back home with all of my experience. And I can't tell you how happy I am to be back home. Hey, so I really want to talk about where my passion for nutrition and honoring our elders came from, and that is from my grandparents. And this is a picture of my grandparents, who I spent a lot of time with growing up, running around in the yard that they're sitting in. Um, they really taught me a lot about nutrition. I've always had a hunger for nutrition and why we're eating the foods that we eat. And my grandmother was very gracious in sharing that knowledge. And I look to my elders as knowledge keepers. Um, my grandpa was a really good storyteller. So a lot of my culture teachings came from them. Some of my tasks growing up as a child was to go out and gather the choke cherries in the yard for grandmother to process. So we had syrup and jelly throughout the winter months. She was also a very avid gardener. She was able to put in a very large garden, very bountiful most years. Um, so I was also able to go out and pick the vegetables we were eating for dinner. My grandpa was known as a hunter and a fisherman. Towards his later years, after retiring from the government, he had several businesses, one of them being a bait shop. So that was also one of my tasks as a child, was going out and selling his minnows and his night crawlers and leeches to local fishermen. So I learned a lot from my grandparents about nutrition. But as they got older and they slowed down more, they started relying more heavily on processed foods. Um, and grandma was diagnosed with type 2 diabetes at a time we didn't know a whole lot about it. I wish I knew then what I know now about nutrition to help her through that. Um, so when we're talking about our elders, we're not just talking about nutrients or disease management. We really do want to have that understanding and that respecting of their culture and supporting their health. So for me, as a dietitian, going back to my roots and really relying on that in my clinical practice today. So wanting to share my perspective. So today I will speak from my clinical viewpoint as a Native American registered dietitian, working within Indian Health Services, serving my people. of the Turtle Mountain Band of Chippewa in North Dakota. And this presentation centers Native American elders as our knowledge keepers, as well as our patients. Very, very important to understand that concept, as they really do hold a lot of knowledge for us. So the objectives for today's presentation, I want to apply trauma-informed care principles to nutrition recommendations, describe the RDAs and RDIs for our older adults, identify nutrition-related barriers specific to Native American elders, recognize the roles of foods in Native American elder diets, I guess both traditional and survival, and then applying culturally responsive and realistic nutrition strategies and clinical interventions. And I want to talk a little bit about the graphic on the left. And for those of you who are not familiar, this is known as a medicine wheel. And this is a sacred teaching tool across many tribal nations. While there are several variations of the medicine wheel, depending on the tribe and the region, the core teachings remain the same, and it's all about balance and connection. So when we look at the wheel through the lens of nutrition, it's not just about physical health, but really incorporating all those pillars of health. So surrounding that center there, and this one I adapted, I chose was for prevention of type 2 diabetes management through sacred teachings. But looking at how we balance all of that in our 4 directions, our 4 colors, our 4 stages of life, our 4 pillars of health. So mental health, spirituality, emotional health, and physical health. And really nutrition plays a part in all of that. But understanding that there, again, this can extend far beyond type 2 diabetes. This can really be used for any chronic health issues or just promoting health in general. Okay, so some of the health disparities among our Native American elders. So we know that, they experience higher rates of type 2 diabetes, chronic or cardiovascular disease, and chronic kidney disease, just to name a few. They experience shorter life expectancy than the general US population. They are at significantly higher risk of experiencing food insecurity. And they went through a really hard time in our history. So they came through historical and intergenerational trauma. And that does continue to impact their health and their trust in the healthcare system today. So that brings me to trauma-informed care and the importance of it. So at IHS, this is something that's a part of our annual mandatory training, but it's very important. So trauma-informed care really looks at the how or the what happened, with our patients instead of what's wrong. And that's really important. So the core concepts of trauma-informed care are safety, trustworthiness and transparency, peer support, collaboration and mutuality with our patients and also our coworkers. Really wanting to empower our patients with their voice and their choice, and then cultural and historical awareness. And all of these are very important and I know we have a very limited time with our patients, but understanding these core principles when we're providing and dealing with our patients is very important. And we'll go through these, as we go through the slides, we'll hit on each one of these core principles. Okay, so going more into the clinical part of nutrition. So I just want to give you some very brief overview of, a nutritional assessment for for our elders. So our elders are they're at risk. There are considerations for older adults like loss of lean body mass, just due to the aging process. A lot of times they're not eating the best due to poor dentition or taste changes. Some of our elders may be experiencing dysphagia, that difficulty with swallowing and chewing properly, renal and GI function changes, and then polypharmacy and nutritional interactions. So all of these are important to consider when we're talking with our patients. And how are we going to provide those nutritional recommendations for our patients? All right, so RDAs versus RDIs, and what is the difference? So our RDAs are recommended dietary allowances, and that's really what drives our clinical assessments and our clinical care. So that's something that we're writing in our charts. We're looking at, recommendations for protein and, especially with our renal patients, looking more specifically at electrolytes. And then how do RDIs play a part in that? So me as a dietitian, I'm able to sit down with my patients and go through nutrition food labels, and that's what we find on our food packaging. Not to be confused with our RDAs, which we use as clinicians. But it is important, to know the distinctions of those and how we can help our patients and empower our patients with the understanding of what they should be looking for on their food labels, especially if they're wanting to control their sodium or look at their potassium or understanding their carbohydrate intakes if they're counting their carbs. So those are very important distinctions to make. Okay, and so for our older population in particular, and I just wanted to pick out ones that were I guess maybe with clinical gaps, focusing more on these nutrients. So protein, it's at the top of the list here. And for our older generation, 0.8 grams per kilogram is an absolute minimum, and very rarely do I use that. Usually, I'm more typically leaning towards one gram to 1.2 grams per kilogram, unless there's other contributing factors. Maybe our patient is not ambulatory, so they're not moving around as much. They're at risk for skin breakdown and pressure ulcers and wounds, or they have cancer, or they're just not the best eaters and they have this unintentional weight loss or respiratory issues. So that can even be increased a little bit more to help that patient maintain their lean muscle mass. And then fiber. So the recommendation for men per day is 30 grams. For women, it's 21 grams a day. And I can tell you with my patients, very rarely are they meeting that. Fiber is so important in our diet. That's what helps regulate blood sugar, especially for our diabetes patients. That's helping control cholesterol. So it's helping prevent cardiovascular issues. Keeping patients regular. So there's just a lot of things that fiber does in our diet. And I tend to focus a lot on adding fiber into their diets. But then looking at calcium, what the recommendations are there, and, with our vitamin D, I can tell you a lot of our patients are vitamin D deficient up here in the north, especially in our winter time. It's very cold. We don't have a whole lot of sunlight. And when we do, it's very cold outside. So we're not going to be outside absorbing that sunlight and getting our vitamin D there. So providing those supplements. And then with vitamin B12, of course, as we age, we don't absorb vitamin B12 as well. And then also, some medications don't allow absorption of vitamin B12 as well. So there are clinical gaps. So looking at low fiber intake, protein inadequacy, vitamin D deficiency, B12 deficiency, and then dehydration is another big one. I know there are supplements. We have fiber supplements and we also have protein supplements, and they do have their place in our clinical practice. But when we're focusing on if we're able to add, higher fiber foods into our diet instead of a supplement, what we're getting from that food is a lot of other nutrients that are beneficial to promoting health, such as phytochemicals, antioxidants, which we know help prevent cancer. And then with protein, we do have those, nutritional supplements that help supplement that protein intake. However, again, we're not getting a lot of other phytochemicals and antioxidants in our diet. So as much as we can, promoting food first and then supplements last. Okay, so going back into historical trauma. So what happened? And so looking at the history of our elders, so a lot of them went through historical trauma. And again, they went through a really hard time in our history. They were relocated to boarding schools. They had a loss of hunting, gathering in our traditional food systems. There was a loss of language and cultural practices, and they were replaced with those survival foods that we were talking about. So those nutrient-dense foods were replaced by these survival foods, and we'll talk about that because they do have an importance when we're talking with our patients. And understanding, and then acknowledging that resilience of our elders, because again, they went through a very hard time in our history. They were able to preserve, even though we had a loss of our language and cultural practices, they did preserve them. I remember listening to my grandparents speak our language, and a lot of times it was because they didn't want to know, they didn't want me to know what they were talking about. But they kept the language and it's still here. And I can't tell you, coming home after being gone for 20 years and hearing my little nieces and nephews in elementary greet me in Ojibwe Mo, and was just so heartwarming. And then going into the schools and seeing things being labeled in our language, it's very heartwarming that we still have our language here, and honoring that. And then our elders, they are storytellers. Like I mentioned, my grandpa, a lot of times, and my grandmother, a lot of things that I learned was through their storytelling. And when I'm sitting with my patients, and I have the luxury of being able to sit with my patients a little bit longer, but hearing, the storytelling, and that's how I find out a lot about my patients. Um, so honoring that, and I know, again, we don't have a whole lot of times with our patients in clinical practice. Um, okay, so our traditional food systems as clinical tools, and how can we utilize that? So food knowledge, and that's very important. So I will draw on my experience when I moved down to my whole goal going through school was to work within Indian Health Services and serving Native American population. I really wanted to come back home, but I didn't have the opportunity right away. So I took a job in Arizona on the Hopi Nation, but I did serve a lot of Navajo patients as well. And I knew nothing about Southwest foods. I knew nothing about living in a desert. Dry farming was something that I was hearing a lot from my patients. And until I asked, can you explain to me what dry farming is? I really did not have a whole lot of knowledge. I drew on my experience growing up on a reservation and living in a food desert, but my foods were different. My language was different. My culture, my customs, ceremonies were different, but they were the same at the same time, if that makes sense. So patients were very willing to share that knowledge with me, which I learned just as much from my patients as they did from me, and utilizing that traditional food. So if you're working on a reservation, or even in urban Indian health, you're probably going to have access to the special diabetes program for Indians. And that's really where I connected when I was working at Hopi with the Hopi special diabetes program for Indians. They were the language experts. They were the food experts. They were the experts in initiating health educational tools out in the community. So I really aligned with the SDPI program, and they are really excited to work, and they really want to work with Indian Health Services. It's a part of their grants. And especially when we have a new provider or someone who's new to the community, they are very open to sharing, their foods and their customs and their traditions. And really wanting you to be out into the community with them. And that's also establishing rapport, because when you have your patients and they see you interacting out in the community, they know that you have an understanding for their culture and their food systems. And there's some really good long-term research projects going on out there if you want to learn even more about how Western versus traditional diets impact the health of our Native American elders. One that I really drawed on a lot during my grad program was the Strong Heart study. Very interesting. So I encourage you to go out and take a look at those. And then also, the special diabetes program, one of the longest running grants in Indian Health Services. It's done a impactful work with our Native American or Indigenous communities. So, and you can find a lot of information on that through ihs.gov. Okay, so going into our ancestral foods, and what does that mean? What is an ancestral food versus a traditional food? So ancestral foods can be thought of as pre-contact. This was what was here before relocation happened, before processed foods or survival foods came on board. So these were our traditional foods. These were foods that our ancestors were out hunting and gathering. They were part of our ceremonies. They really do identify us as tribal nations, as communities. So when you look at the three sisters, the corn, beans, and squash, and something very interesting about the three sisters is when you eat these three together, they actually make a complete protein. And this was important as I was working down in Southwest tribes, because they are predominantly vegetarian eaters. They do have their big game or their wild game, but they do a lot of corn, beans, and squash. And then up here in the north, Monoman wild rice is one of our main carbohydrate staples, along with our berries. But then fish, wild game, and these are all examples of very high fiber, nutrient dense, lean protein foods. These are the types of foods that promote health, that kept our ancestors healthy, not only in the fact that eating them kept us healthy, but the act of going out and acquiring these foods, because it took physical exertion to go out and to hunt and to gather and to forage, and to take care of these plants when we were growing them. And then after relocation happened, our food systems were disrupted and we were replaced with survival foods. So when you're looking at this, you're seeing a lot of refined carbohydrates. This is where Spam comes into the picture. Fry bread was born. Um, but this also served an important time in our history because this also saved our people from starvation. It filled that void of hunger. It sustained life, even though it didn't promote health. It sustained life. So these foods are still commonly eaten today. And you think of Spam. I remember my grandmother had a closet that was dedicated to these types of foods and this packaging in particular. But it was nothing for her to open a can of Spam and to make that for us grandkids as we were running in and out of the house. So it's something that, again, is in fry bread. If you go to any reservation, we have our own version of fry bread. So to ask somebody to take that off, all of a sudden, we're just not going to recognize these as something that we're going to talk about is really not realistic to a lot of our elders. And that brings me to traditional. So traditional is can be thought of as, our ancestral foods and then our contemporary or these newer survival foods. And this picture here, and I know it's not necessarily all ancestral foods, but on the left, you see whole foods, and then on the right, you see these more processed or survival foods. And then in the middle there's just kind of this blankness. So what are we going to do with this? How are we going to put this together when we're working in clinical practice? Because we do have to adapt. We have to adapt with our patients because we have to meet them where they're at. If they don't have access to a lot of these foods on the right and all they're dealing with is foods on the left, how are we going to help them with that? And these foods, and again, a lot of these foods, the processed foods have made their way into our ceremonies because they're, they can feed a lot of people. And again, they were our survival foods. So they did serve a purpose in our history. So we do have to recognize that. So how are we going to do that? So we can focus on reconnecting and not restricting. And that, when I was in dietetic school, we didn't have a whole lot of, we did have a section on, cultural awareness. But really a lot of what I was learning was really not something that I grew up learning. So applying my dietetics, my clinical experience to coming home and to working with with our Native American population, I really had to learn and humble myself and understanding we don't need to restrict, but we can reconnect and what can we add to our diet instead of taking away? Because if we talk about taking away something, we don't have anything to replace that with. So what can we do with our foods? How can we label food as, avoid labeling our food as good or bad, and avoid food shaming? And that will really be impactful with your patient. And that will really start establishing that rapport and they will feel heard and understood. So here, I just wanted to give a little overview. This is how can we modify our survival foods. So anybody who's from the Turtle Mountains probably recognizes what this is. This is our bullets and bangs, and this is a traditional meal during New Year's or special occasions. We call our fry bread bangs, and if you hear the word bangs, that's probably somebody from the Turtle Mountains because we're one of the few tribes that call it that. But what I did with our fry bread is I typically will fry in canola oil. I'll reduce and I'll try to incorporate more whole grains in there, more whole wheat flour. And I know down south, what they actually do is grind their blue corn and they add that into their fry bread dough and they'll add in their culinary ash, which is ingenious. I mean, they're really being innovative with how they're adapting their ancestral foods and their survival foods. So here I'm frying in canola oil. I'm and the bullets is the stew. So that's basically potatoes boiled with hamburgers rolled in flour to make that gravy. I typically will add more vegetables to this. I'll add sweet potatoes. I'll also make A berry boil, so something to dip your fry bread in. And that berry is just simply frozen berries with water and a little bit of cornstarch, a little bit of maple syrup. And that's just increasing fiber intake, antioxidants, phytochemicals, some of those things to just adding more fiber and nutrients into this meal. But again, I would never tell my family members or somebody here, we got to stop eating bullets and bangs because that's just not, nobody's going to listen to me. I'm going to lose credibility. Um, but instead modifying, and then we can really watch our serving sizes too. So reducing those portion sizes as well. And then looking at barriers with our patients. So understanding what barriers our elders have. A lot of them are living in food deserts. Even if they're living in an urban setting, they could still be living in a food desert. Um, and then having limited personal or public transportation. They're on a fixed income. Communication is a huge barrier. I know when I was living in the Southwest, a lot of the elders that were coming to me, English was not their first language. We had to have interpreters come in. And again, through their storytelling, really being patient with that individual and letting them tell their story in their own language, in their own version, and understanding where they're coming from and meeting them there. And then caregiving. So a lot of our elders are providing care to, their grandchildren, or they have caregivers with them. And I always welcome, the family setting and into my office. Just, bring whoever you want with you, whoever you feel can benefit from what we're going to talk about. You can bring them with you. If that's your caregivers, if that's your grandchildren, please bring them. And I also recognize that a lot of clinicians have very short appointment times. So taking all of this into consideration, and with nutrition, I always say every bite counts. So let's make every bite count. So let's make it impactful. Let's make it full of vitamins and nutrients and protein and slow digesting carbs. We can do the same thing with our time. Make every minute impactful. And then standard health pamphlets, they don't always necessarily align with what elders' realities are. So how can we modify those pamphlets? How can we provide something with our patient that's really going to help them with all the barriers that they're facing? And that can be, IHS.gov does have a lot of resources that I encourage, and they're free. I encourage you to go and look at those. My native plate is a really good one, and I'll talk about that on the next slide. Consistent carbohydrate intake. So instead of, maybe those patients, and a lot of times my patients are coming in and they're only eating one meal a day, and it's a big meal. So how can we take that and kind of spread out their meals throughout the day to help stabilize their blood sugar if that's the goal, managing blood sugar instead of just eating once a day, and help them avoid skipping those meals. And then focusing on adding fiber. So that's really important. And I really do a lot of focusing on adding fiber. Hypertension and chronic kidney disease. So we can look at the DASH diet. We can look at DASH seasonings, but then again, what can we use that's flexible with that patient? So diabetesfoodhub.org is another really big resource that I use with my patients. You do have to have access to internet, and a vast majority of my patients do have access to the internet. So I will go through this. I'll pull it up right on my computer, and we'll go through this website, and I can show them how they can filter through this website, and they can pick out recipes to use as inspiration. Really, they can modify the recipes to use the foods that they have access to. So we go through that, and this website is evidence-based. There's a lot of research that went into it. There's a ton of recipes. They can use it for planning out their whole meal, compiling a grocery list. And then you can filter out recipes that can help deal with chronic kidney disease, that are all heart healthy. They also have a kid-friendly menu. So this is a really good resource to share with your patients. Even if you're not able to go through it with them, if somebody's looking for recipes, and a lot of time my patients are looking at recipes like through TikTok or YouTube. And I'll tell them, well, this is another good resource then if you're able to do that. Because on here, you can also sign up for free cooking classes, virtual cooking classes. So that's a good resource for them. And then through Indian Health Services, some of their nutritional handouts, and again, these are free, and you can order these for free if you're working with an Indian Health Services or with Urban Indian Health. So these are tear offs that you can, and they're placemats. But then there's also a lot of other resources you can order in for free or or use as inspiration to modify for the community that you're living in. So my native plate, and this is for my visual learners, and I'm a real big visual learners, if you can't tell from my presentation, I love my visuals. Um, but going through this with patients and um, looking at their plate and how can we um, fill up half your plate with non-starchy vegetables or high fiber foods, and then looking at a quarter of your plate being your grains or your starches, and then your protein, which doesn't always have to be meat. But then looking on the other side, this is the flip side of that. On the right side here, that's the flip side of that, my native plate. And it goes through breakfast, lunch, and dinner ideas, and then just some nutrition tips. And again, this is something that's it's pretty broad. It covers a lot of different foods, but then you can make it more specific for the community that you're living with. So you can use this again as an inspiration or as a guide to work with your patients, or you can just go through it and what kind of vegetables would you place on the side here, or what do you like to cook that's a grain or a starch. Um, all right, so nutrition strategies for Native American elders. So screening for food insecurity, and that's pretty important when we're dealing with our Native American elders, because if we're giving them recommendations on all these foods and they're just worried about finding their next meal, we need to meet them there, not overwhelming them with a bunch of nutrition recommendations. We need to meet them right there and helping them get those resources. And again, this link here is from IHS.gov. So that's a good guide if you want to use it as it stands, or again, you want to tailor it for your practice or your for your patients or your community. Even, again, if you have a lot of patients who or those elders that don't speak English, you can have an interpreter sit down and we can write it in their language. If you have access to a dietitian or a social worker in your area, providing those or giving those patients a consult or referral to those dietitians, social workers, so they can help continue the education or the process of promoting health through finding food access and nutrition education, and then relying on those tribal assistance programs, because there's a lot of them out there. A lot of reservations are, they do have some established food assistance programs, and sometimes they are focusing on their own traditional or ancestral foods, which is great. So getting out there, and again, you can find those connections if not through the clinic you're working in, through the SDPI program. Or just contacting the tribes and asking them, what are your food assistance programs that I can share with my patients? Providing culturally based resources, pamphlets, nutrition tools, and best practices. And again, you can use that IHS.gov website and then your tribal stakeholders as well, because I know that when I was working down at Hopi, they did have a lot of, and they called it Hopitizing their nutrition handouts. And patients really did gravitate towards those because they seen their culture being represented. They used a lot of art, and it was really beautiful, just beautiful educational tools that they were able to provide to their patients. So this is, and there's a lot of food initiatives out there as well. So if you have an opportunity to attend any of these within your, the community that you're working for, I highly encourage you to. This is something that I started down in Hopi, and I collaborated with Physicians Committee for Responsible Medicine. And I was able to connect with two Indigenous chefs, Dr. Lois Ellen Frank and Chef Walter Whitewater. And we provided a Native Food for Life, a 6-week course, and then also a finale where we did a whole food taste testing that was free for everybody. And we did a lot of education along with that. But then moving home, I know they really wanted to come. They were really interested in coming to the Turtle Mountains. And through collaborating with the chefs, I was also able to connect with Dr. Melissa Nelson, who is from the Turtle Mountains. And we came home, and for 2 years in a row now, we've provided this here in the Turtle Mountains, the Native Food for Life. And this also, with having the chefs here and Melissa, who's a doctor, ecologist, we connected with the Anishinaabe campus through our college here, and they have a state-of-the-art greenhouse. They have community gardens. So we were able to kind of collaborate and start networking and combining our initiatives together. creating that food sovereignty for people. And that truly was culturally grounded. And then helping support chronic health disease prevention and strengthen that identity through our indigenous food systems. Um, again, I highly encourage you to get out and participate in any of these in your community. So if you see any of these flyers, get out there. And it helps with the patients too. If they see you out there, they're able to connect with you outside that clinical setting and building that rapport. Okay, so putting this all together. So um, recognizing trauma-informed care application is very beneficial and useful with our clinical practices and our patients. Looking at RDAs and how they drive assessments, but our recommendations and our culture drives connections and change. So putting those two together, and then looking at food as medicine and really recognizing our traditional foods, both our ancestral and our survival foods. And I'll share with you when I was down working for Hopi and I was learning their traditional food systems and reflecting on what the previous presenter had stated that we are but corn. Corn is, very sacred. It's in all their ceremonies. Their language depicts, it's all centered around corn, and they have 4 different colors of corn. They have white, red, yellow, and blue, and that's their traditional colors. And I had a woman come to me and she was devastated. She had just received a diagnosis of type 2 diabetes and was told by her provider that, she shouldn't eat corn anymore because it's a starchy vegetable. And she was the matriarch of her village. It was her job to process and to prepare and to cook corn and to eat it with those that were coming to her house for ceremonial reasons, for prayer. She was really devastated. And I know it didn't come, it was, I know the provider didn't necessarily know the impact of what they said. So I sat with that patient for a long time to just go over, what that meant, just eating it in moderation, because it can, increase your blood sugars. But if we're eating it with a lot of other high fiber foods and our proteins, so just really having to sit with that patient and talk them through it. So no, yes, you can definitely still eat your traditional foods because they look at that as their, they're that's what keeps them well and nourished and healthy. So really watching, understanding and that's the importance of understanding the cultural foods of the area that you're working in. And also knowing that success is not perfect labs. And I know we all know that, but success can be building rapport and trust, hearing our patients and their concerns and their questions, and that change over time, looking at those SMART goals, specific, manageable, achievable, realistic, and time bound. So setting those with our patients, just those small goals, and over time, looking back, how much you've achieved by setting these small goals and achieving them, and how much change and you have made. And then cultural responsiveness and putting this all together. So going back to that trauma-informed care, really empowering our patients, because when they walk out that door, we want to empower them to make those choices that are promoting their health, that are making them feel like they can do it, that this is totally within their realm. Now they have the power. And then when they come back, they can come back and ask questions because now they're more empowered. They have more knowledge of what they need to be doing. So that's really what we want to do with our patients. And I know I'm really ahead on time, but so that brings me to the conclusion of my presentation. And I just want to end with saying, Chimigwech, thank you so much for caring for our Native American elders. Thank you for listening with openness, and thank you for the important work that you do in our community. So I do have some time here for questions.